Imagine standing over a patient in the operating room, their chest torn open from a car crash, heart stopped, and every monitor screaming death. Yet they're whispering your name, describing a surgery you performed 15 years ago that no one could know about, down to the exact suture pattern you used. Now imagine their wounds start closing on their own as you watch, defying every law of medicine. That's what happened to me on a chaotic night in June 2024, and it's why I question everything I thought I knew about life, death, and the human body's limits. My name is Dr. Rachel Nguyen, and I've been a trauma surgeon for 19 years at St. Vincent's Medical Center in Portland, Oregon. I've performed over 4,500 surgeries, from gunshot wounds to multi-vehicle pileups, saving lives most would call unsalvageable. St. Vincent's is a Level 1 trauma center, handling 1-200 critical cases annually with a 20-bed ER and 3 operating theaters. I've seen miracles, but nothing like the case of Patient X, which broke every rule of physiology and forced me to confront possibilities I can't fully explain. June 12, 2024, was a stormy night, the ER buzzing with victims from a 6-car collision on I-84. At 11:47 p.m., EMS wheeled in Patient X, a 32-year-old male, no ID, listed as John Doe. He'd been ejected from a vehicle, suffering catastrophic injuries, open chest wound, multiple rib fractures, punctured lungs, and a severed aorta. His heart had stopped en route. CPR was ongoing. By all metrics, he was dead. Zero pulse, flatlined EEG, pupils fixed and dilated. We rushed him to OR3 for a last-ditch thoracotomy. As I cracked his sternum, preparing to clamp the aorta, Patient X's eyes snapped open. "Rachel," he rasped, voice clear despite no detectable heartbeat. "You saved the boy in 09, the one with the glass in his chest. You used 4-nil Prolene sutures, figure-8 pattern." I froze. In 2009, I'd saved a teenager with a shard of glass through his heart, using exactly that suture technique, a case never documented publicly, known only to my surgical team. No one outside that OR could have known. Yet this man, clinically dead, recited it like he'd been there. I checked the monitors, still flat. No blood pressure, no oxygen saturation. "Focus, Rachel," he said as if coaching me. I shouted for the team to resume compressions, but his chest was a mess. No amount of surgery could restart a heart this damaged. Yet he kept talking, describing the 09 surgery in vivid detail. The boy's blue sneakers, the flickering OR light, my exact words to the anesthesiologist. 10 minutes into the surgery, something impossible happened. The jagged tears in his lungs began to close, not gradually, but visibly, tissue knitting together like time-lapse footage of healing months. The severed aorta, which I'd clamped to stem catastrophic bleeding, started pulsing faintly, edges fusing without sutures. I've seen rapid clotting in trauma, but this was different, flesh regenerating at a cellular level, defying biology. The surgical tech, Maria Santos, gasped. "Is that supposed to happen?" It wasn't. No human body can repair itself like that. I ordered intraoperative imaging to confirm what we were seeing. The portable X-ray showed fractures realigning, bone fragments merging without intervention. The ultrasound revealed lung tissue reforming, alveoli reconstructing in real time. Yet the monitors still showed no vital signs, no heartbeat, no brain activity. Patient X's eyes remained open, tracking my movements, his lips curling into a faint smile. "You don't need to fix me, Rachel," he said. "I'm already being fixed." As we stabilized what we could, Patient X began describing other surgeries, cases from my career I'd nearly forgotten. A 2012 splenectomy where I'd nicked an artery, a 2017 gunshot case where the patient coded twice. He knew details only I'd recall, the music playing in the OR, the weight of the scalpel in my hand. Most chillingly, he described a botched appendectomy from my residency, a case that haunted me because the patient died, a failure I'd never disclosed. "You cried in the locker room after," he said. "You still dream about her." He was right. I do. I demanded, "Who are you? How do you know this?" He didn't answer directly, only said, "I've been with you, Rachel. In every OR. You just couldn't see me." The anesthesiologist, Dr. James Lee, checked his pupils again. Still fixed, yet patient X was speaking. Lucid, as if his brain wasn't starved of oxygen for 20 minutes. Post-surgery, I moved patient X to the ICU. Though stable didn't describe him. Monitors still read death, yet he was awake, breathing shallowly. I scoured hospital records for any trace of him. Nothing. No John Doe matching his description. No EMS report beyond the crash details. But I found something worse. Over the past 30 years, St. Vincent's had 19 undocumented miracle recoveries. In the ER, patients with fatal injuries who survived against all odds, all with no clear identity, all discharged without follow-up. 7 cases mentioned patients speaking without vital signs, with details eerily similar to mine. I cross-referenced the crash site. Local news reported 6 fatalities, but no mention of a 7th victim, patient X. The police had no record of him either, as if he'd never been in the wreck, yet his injuries were consistent with high-speed ejection, down to the glass embedded in his arm. At 3:15 a.m., the ICU monitors began glitching, not just patient X's, but every patient's in the unit. Heart rates spiked, then flatlined, then normalized, all within seconds. Nurses reported hearing whispers from empty rooms, calling out names of former patients who'd died in the hospital. I checked on patient X. He was sitting up, unhooked from monitors, staring at the ceiling. "They're here, Rachel," he said. "The ones you couldn't save. They're helping me now." I looked where he pointed. Nothing but shadows, yet the room felt colder, the air heavy. Security footage later showed static bursts across all ICU cameras at 3:15 a.m., with faint outlines of figures in rooms that were empty. The hospital's electrical system, recently upgraded with new MRI and CT scanners, had been emitting low-level electromagnetic interference all night, according to maintenance logs. I wondered if it was connected. By 5 a.m., patient X's vitals finally registered. Normal heart rate, blood pressure, EEG. His chest wound was nearly closed, leaving only faint scars. I ordered a full CT scan, but when the tech arrived, patient X was gone. No alarms triggered, no doors opened, no footage showed him leaving. His chart, left on the bedside table, had a handwritten note in my own handwriting. "You're not done saving them." I've never written those words. The ink was fresh, the pen still in my pocket. Staff reported seeing a man matching his description in the ER waiting room at 5:03 a.m., but he vanished when approached. The hospital's visitor logs showed no record, and the crash site had no trace of him. Yet his blood samples, taken during surgery, tested positive for rare isotopes not found in earthly environments, similar to cases I later researched in medical journals. I spent weeks investigating. Across the U.S., 34 trauma centers reported similar cases since 2020. Patients with fatal injuries surviving impossibly, often knowing intimate details of their surgeons' lives. All cases involved electromagnetic anomalies, glitching monitors, flickering lights. Several hospitals were near old burial grounds or sites of mass casualties like St. Vincent's, built on land once used as a Civil War hospital. I found a 1998 case where a patient, pronounced dead, sat up mid-autopsy and described the pathologist's childhood dog down to its collar color. Patient X's isotopic markers matched reports from a 2022 case in Vermont, where a patient healed from a crushed skull and vanished. The radiologist on that case, Dr. Sarah Lynn, noted scanner glitches showing extra tissue that disappeared, just like my patient's CT anomalies. 3 months later, I began having nightmares of surgeries I'd never performed, patients with faces I didn't recognize, injuries healing as I operated. In one dream, patient X stood beside me, guiding my hands, saying, "They're all here, waiting." I woke to find my surgical scrubs, clean the night before, stained with blood I couldn't explain. Lab tests showed it wasn't mine or any known patient's. I've since learned of 12 other surgeons at St. Vincent's experiencing similar dreams, all tied to patients who shouldn't have survived. Our hospital's new MRI suite, installed in 2023, emits EM fields stronger than industry standards, possibly amplifying these events. I theorize that certain individuals, maybe due to trauma or exposure to these fields, become conduits for something beyond life, entities, or energies that manipulate biology to persist. The isotopes suggest they're not entirely of this world, perhaps crossing from somewhere else through rifts caused by modern technology. If you're a trauma surgeon, watch for patients with impossible recoveries or knowledge of your personal history. Document vitals, injuries, and exact words. Check for EM interference from hospital equipment, MRI machines, monitors, even Wi-Fi routers. If you're a civilian, avoid high-risk areas like crash sites near old hospitals or burial grounds, especially during electrical storms. If someone survives an accident they shouldn't, don't assume they're lucky. Monitor them closely. Patient X taught me that survival might not always be human. Some patients walk out of the OR, but they're not the ones who walked in. Somewhere out there, he's still healing, still carrying the stories of every surgery I've ever done, and maybe others I haven't yet. The body can mend in ways medicine can't explain, but what's mending it might not belong to this world at all.